Thank you. Thank you. Well, thank you. Thank you to Dr. Sharon O'Toole for inviting me, and to Ovacare, and to all of you for coming today. I'm a medical oncologist, so I'm your chemotherapy doctor. And my talks usually come from the questions that I get in my clinics, and I just try to share them with you. So even before I begin, can I just ask, did anybody come in here with a burning question? Any burning questions? You did? Yeah. Don't you usually leave the consultation and go, oh, I forgot to ask that? So what is your burning question?
Do you really want to ask it now?
Okay, well, it just gives me an idea. People can shout out questions if they want, and then I'll just try to get them as well.
I would like to know about embolization.
About, sorry?
Embolization.
Okay, that's good. Embolization, that's a good question. Okay.
And just about the use of aromatase inhibitors in low-grade serous ovarian cancer.
Wow, that's a good one. Okay. Anyone else? All right, there are questions out there. The one thing I just wanted to say to all of you is, do you guys carry a notebook with you? Would you carry a notebook with you? Do you? That's fantastic. You know what I found is that I'm not smart enough for my smartphone. I don't know how the rest of you feel about it, but I ask all my patients to carry a notebook. And then what I tell them is when they come in and talk to me, they hand the notebook to whoever is with them. Because what we find is when you're in a consultation, you come in with questions, you have your agenda, your doctor has their agenda, and you're both trying to meet each agenda. And you sometimes forget to ask things or forget to write them down. So I tell everyone, start carrying a notebook. It's a really good idea. Okay, I'm just going to start out. I'm going to talk a little bit today about the biology of ovarian cancer, only because that's it's the thing I really do like to talk about, but I'm not going to get into depth. I'm going to talk a little bit, and it is why some people are treated differently than others. I'm also going to talk about some of the current treatments and some of the future treatments, okay? And just as I begin, I thought I'd put that up there. This is a cancer cell. Just if you've never seen one, this is what they look like. And they have these long, they're called pseudopods, and that's what makes them a little bit sticky. But it doesn't look just like that. That's a picture of an electron microscope. The human body is much more free-flowing and sort of gelatinous, and that's why I like to look at this picture of cells. So the first thing I'm just going to talk about, Rory, I'm sorry I missed the first part of your talk. I might double a little bit up, and I recognize we have a surgeon in the room, so this is the non-surgical guide to your human anatomy. But I often get asked the question about ovarian cancer is, where is it? And a lot of people think of cancers as a ping pong ball, one thing. And it's not just one thing, okay? So the first thing is where is it? And if we think about it, it's down here. But everything from your diaphragm down to your hips is basically kind of an open box. So if I opened that up, I would see a lot of things. I'd see 40 feet of bowel. I would be able to see your stomach. I would see a lot of other bits, but if I went way down and in, I would see the uterus, the fallopian tubes, and the ovaries. Everyone with me? Mm-hmm. Yeah. And this bit over the top of it is kind of our airbag, if you so to speak, is we have a layer of fat to help cushion us when someone hops on POP or whatever they do, but we have a layer that cushions us, and that is a layer of fat. And that's actually important in ovarian cancer because that is an area that collects some of the cells. So when we think about ovarian cancer, we think that it begins in the ovaries, really the lining of the ovaries, or in the tubes, but then it develops in other parts of this box. Is everybody kind of with me on that one? Mm-hmm. Yeah? Okay. So not a ping pong ball, several different things. Now you might have heard the term primary peritoneal cancer. Has anyone heard that? Mm-hmm. Yeah, okay. Well, they're cousins, so to speak. And the lining of the ovaries is the same as the lining of this box. So when Rory goes in to do a surgery and opens things up, it's sort of like everything's wrapped in I call it saran wrap, plastic wrap. That's what the peritoneum is. And they share a common origin. So cancers can develop from here or from this lining. Okay, that's a question I actually get quite a lot. Now, when you meet other people who have cancers, a lot of times you compare treatments and you find that you're not on the same treatment, you wonder why. It's because not all cancers are alike, even ovarian cancers. So the first thing I wanted to say was, here we go again. Do you feel like you're back in biology? Human anatomy. Here's the uterus, the fallopian tube, and the ovary. And here's the ovary close up. And really, the cancers that are most common come from the lining of the ovary. Rory, feel free to jump in anytime if I don't have this right, okay? Okay. Now, so when we think about ovarian cancers, the majority of them come from the lining, and only some of them come from inside the ovary. Okay? Everyone with me now? The reason I think this is important because when you get on the internet and you want to read about it, it helps to have a little bit of background. So, of this group, the lining of the ovary, there's different cell types: serous, endometrioid, clear cell, and mucinous. I don't know if some of you read that. Do you get on the internet? Mm-hmm. Yeah, a lot. Okay. So that just gives you an idea. When we're sitting down thinking of something, we're not just saying ovarian cancer. We're thinking, okay, it's ovarian cancer. What is it exactly? And we're thinking this. And then we're thinking, where is it exactly? And that helps us to understand the staging of it. Have you heard the word staging? Yes. Okay. So staging is really used by doctors to talk to each other. And it's also used to talk to you, but it was initially developed so Rory could be on the other side of town and I could be on the phone and I could explain to him it is a stage 1, 2, 3, 4, and he would know what I was talking about. Now, it refers to extent and the location. And based on the stage, it helps us to understand what are the guidelines for treatment, what are the possible complications, and how do we help prognosticate? How do we help think about how you might do? Okay? Now, this just gives you an idea of how things move in the body. So here we are again, we're way down here. But some people might have developed ovarian cancer in different spaces, right? Sometimes up here in the liver or here in the lungs. And they say, how did it get there? You told me this was one big box. Well, it goes there through lymph channels or the bloodstream. Now that is really important for me because that's how we're going to treat you. Everyone still with me? Okay. I always put up pictures of female surgeons. Sorry, Rory. So the treatments for ovarian cancer are many, and it's us determining the proper sequence of treatment for you. And surgery is a pillar of what we do in ovarian cancer. There are different ways to give chemotherapies. One is directly into the abdomen, which is not widely used yet, but a recognized method. There's intravenous chemotherapy. There's antibody therapy. We're hearing a lot more about immune therapy. And there is radiotherapy, which we use in selected cases. Okay, so I'm going to talk a little bit more about the chemo, antibody, and immune therapies. You might find in the room here that if you talk to someone next to you that they had surgery first and then had chemotherapy. And other people had chemotherapy, then surgery, then chemotherapy. Or some just had chemotherapy alone, or some have chemotherapy with an antibody. And all of these are right. But we have to know where you are, what is the location and extent of your disease, and then we decide what the appropriate treatment is. And I echo exactly what Rory said, is we follow international guidelines. So first, I'm just going to talk to you a little bit about chemotherapy. I love chemotherapy. There might be a lot of people in here that don't really like chemotherapy, but it actually, it does work, and it does what it says it should do. Now let me explain to you what it does. Chemotherapy goes in to the bloodstream, and your bloodstream is connected to every cell in your body. Every cell in your body needs the nutrients that the bloodstream brings, okay? So when we put chemotherapy into your arm or into a port, anyone ever know what a port is? Yeah, okay. When we put it in there, it circulates around the entire body, right? And we know that. How do we know that? Because you often lose your hair. So we know it's circulating everywhere, okay? Not every chemotherapy causes you to lose your hair. So what does a chemotherapy do? A chemotherapy travels through the bloodstream. It meets fast-growing cells, which are cancer cells and also hair follicles and things like that. It digs in, it gets into the cell, and it causes the cell to fall apart. That's how chemotherapy works, okay? And chemotherapy is an absolute foundation of most cancer treatments. Now, the problem is with chemotherapy is that you kill bad cells, but you also kill some good cells. And the whole idea is that if you kill bad cells enough times, they won't regenerate. They can't regenerate with the same amount of vigor. Whereas healthy cells, if you knock them down, they recover, just like your blood counts. Anyone following your blood counts, right? Okay. You have chemotherapy, blood counts go up, they recover. They go down again, they recover. They're healthy. These are different chemotherapies that are used in ovarian cancer. Now in the last few years, our practice has changed actually from one that just gave chemotherapy to now we're giving chemotherapies and antibody therapies. And antibody therapy is something called Avastin. Have you guys anyone heard of Avastin? Yeah? Okay. All right. Now this isn't a chemotherapy. It doesn't kill cells. So what Avastin does is, I'm going to go back over here. You can hear me okay if I give a shout? All right, yeah. So this blue thing here is a tumor, okay? And they're actually kind of clever in that they send out a chemical signal to blood vessels and they say, come here, come to me and give me some nutrients, all right? And that's the chemical signal they give off. It's called vascular endothelial growth factor, okay? What Avastin does is it doesn't really pay any attention to the cancer cells or the tumors or anything like that. What it does is it goes and mops up all those chemicals that it spills out so that the signal to invite blood vessels towards a tumor is dampened. So what happens is you starve the supply line, okay? So this is like the wagon trains trying to get in and deliver goods. You try to stop that from delivering. So Avastin, we found, has, at first, about a decade ago, we didn't know how to use Avastin in ovarian cancer, and we found that actually we had problems with success, is that it worked too quickly. And we had difficulties with bleeding and with clotting. And now actually we're finding better ways to deliver it, and we deliver it with chemotherapies. And then we oftentimes stop the chemotherapies and keep the Avastin going as a maintenance. Anyone familiar with that? Some are? Yep. Okay. So that's how Avastin works. And that really has changed our practice in the last 10 years for medical oncologists. We're seeing people that stay off chemotherapy longer when they get to go on this Avastin maintenance. Now, you're hearing about some new therapies. And one new therapy is called a PARP inhibitor. Has anyone heard about these? Yeah, okay. We're still trying to understand this better. But what PARP inhibitors do is they prevent tumors from putting themselves back together and trying to grow again. They take down the scaffolding, basically. But they seem to work really well in women who have inherited types of breast and ovarian cancer, but particularly ovarian cancer. Does anyone know about inherited types of ovarian cancer? Yeah, and it's called BRCA, or BRCA. Yeah, Angelina Jolie informed the world, actually. But that's where this drug is being used more. Now, it's not being used up front. It's being used second and third line, and we're trying to understand where is the best place to use this. But this is one to watch for everybody, okay? And I think we'll be seeing more of it. I think we'll also understand not only if it's useful in hereditary kind of BRCA type cancers, but if it's useful in other types, serous, endometrioid, and things like that. Have you heard of immune therapies? You've been reading the newspaper. It's been, the last 3 years, there's been a lot of information. Now, I gave a lecture 5 years ago, and people used to say, what can I do? Can I boost my immune system? And I was like, no, you can't. You know, you can't boost your immune system. But I was wrong, and now we actually can. So this is another example of a drug given that pays no attention to the cancer. Doesn't even look at the cancer. Immune therapies, what they do is they go into your body and turn on your immune system, who seem to lose the recognition for this growing thing in your body, okay? So let me just walk you through this. The tumor gives off proteins called antigens into the bloodstream, okay? One antigen, sometimes you can test in your bloods. Do you know what it is? What is it? Anyone get this blood test? CA-125, exactly. That's it. That's one of the proteins it gives off, okay? And then what happens is, in your body, we all have these cells that are looking around for little aliens. And when you get a cold or a flu, this is the cell that recognizes there's a problem. And it picks that thing up and it says, it goes to the T cell, which is our immune system, and says, hey, wake up, should we attack this? And the problem is our T cells, for some reason, with a lot of cancers, aren't activating. They're going, no, that's normal human body. And in fact, they're right, because cancer cells are normal cells, but they've just changed in some way. So they just don't turn on. What immune therapies do is they come here and they say, wake up. And they actually, this is an example of, it's called Opdivo, which is one of the immune therapies, but waking up a T cell and saying, come on, look, this is it. And the T cell then going, oh, right, that's what we should be doing, and attacking the tumor. Now, it sounds great, and in some cases it is great. The problem is once you activate your immune system against self, because this was originally a normal body cell, right? The immune system then can attack other bits of self. So you can get immune side effects, thyroiditis, thinking about your immune system. So that it comes with many different kinds of side effects that we've never seen before as oncologists. So we're just getting to understand how these drugs work. What's not clear is how well they're going to work in ovarian cancer, but they are being studied. So I thought it'd be good for you to know how this system kind of works, and then good to know that when we think about immune therapies, we don't just think about, the one that's always in the news here is ipilimumab. You guys have heard that one with melanoma, yeah? But we think about it as some of the antibody therapies is actually an immune therapy, vaccines, immune cellular therapy, activating your T cells outside your body and putting them back in, and then the drugs that we're seeing more in the clinics, PD-1 inhibitors and ipilimumab. So this, again, is another space to watch. And the question that we have as oncologists is, do these work well alone? Should we be using them with chemotherapies? Should we use them early in the disease? Do they only work later in the disease? who should get them? What if you already have an immune problem, or rheumatoid arthritis, or lupus, or something like that? So we too are trying to understand, where do these drugs fit? But this is something that is definitely already in clinical trials. So I wanted to, those are big sweeping slides. And I'm sure we can, when we have a question and answer session, we can answer some of the other questions. But I wanted just to give you some good news slides as well while I'm here. Is first of all, I want to show you this. So this is the number of new cancer therapies and the number of cancer survivors. So let's follow the blue line. So this is the number of new cancer therapies between 1980 and 1990. There were about 30 new therapies, and about 40 new therapies, and then more than 40 new therapies. All right, so really in the last decade, now we don't have the data a little bit further, our therapies have increased almost exponentially. Now look at the survivors curve. Is that as we develop new therapies, the survivor curve improves as well. So this is what drives us to find new things. So that's a good news slide, and that's actually, I'll just put a note in here, why clinical trials are important. And you should always ask about them. They're not as plentiful in ovarian cancer, but I think that is changing. So keep that in mind. These are some of the resources that I use and I think might be helpful for you to use as well. So if you have a camera, just take a picture of that. But I just walked through these. Clinical Trials Ireland, there are only 34 medical oncologists in the country. And as far as clinical trials go, we all work together. So there are only a few sites that open clinical trials in ovarian cancer, and we tend to, if there's a trial ongoing and we have a patient who is a candidate, we will send them. You can look at their website and you can search their trials. The second one is nccn.com, and this is a very good website just for reading and understanding, and it also goes through some clinical trials. There's a UK clinical trials gateway, and then finally there's another site, cancer.gov. Now I just wanted to say a couple of things. I wish we could get all things for all people. We can't, because the drugs that we give have some terrific benefits and some really significant side effects. So be mindful that the things that you get from your medical oncologist have to be the standard of care, and those are fully approved and licensed, okay? Meaning that they're licensed in Europe and they're fully approved in Ireland. There are some times that we can get drugs on compassionate use. And what this means is that they are licensed, but they haven't made it through the approval process, administrative process in each country. So sometimes that can happen. And finally, that should be number 3, our clinical trial drugs, which are still completely on clinical trial. And trials are meant to offer you as a patient either the standard of care or what we think may be equivalent or better than the standard of care, but we haven't proved it. So it could turn out to be slightly less than the standard of care, but when it gets into clinical trials that are available to you, generally we feel that there's an equivalence or it might be slightly better. So important just to ask. I've got 3 slides left. I just wanted to say one thing about this. Now, we talk all about treatments and everything that's happening. I just wanted to remind you that this ovarian cancer is not a race where there's a starting point and an ending point. In my mind, it's something, this is where survivorship comes in, and I like this word, the term, because it's the process of living with, through, and beyond. And so by definition, cancer survivorship begins at diagnosis, and it includes people who continue to have treatment either just to reduce their risk or to manage the disease in an ongoing manner, okay? So on the day of diagnosis, that's a really difficult day, but you're a survivor. When you're getting your surgery, you're a survivor. When you get your treatment, you're a survivor. And I want to keep pushing that point home. One thing that I find really important in the literature that I think a lot of people, when you're looking for new treatments and new things, is we forget some of the most basic things. Number one is there is no diet or supplement that truly has ever been shown to reduce the risk of cancer and make the disease process better once you have cancer. All right, now I take smoking out of that one, and a couple of things out of that one, but people come to me about the Atkins diet, the Mediterranean diet, a vegan diet, a macrobiotic diet, and you know, we've tried, we've looked, and we just can't nail a diet down, otherwise we'd all be recommending it. So I say eat well, eat reasonably, eat the things that are good for you. I sound like your mother, but that's what you should be doing. But the one thing in the literature that through the last 5 to 10 years continues to rise to the top is exercise. And this is true in all diseases, but particularly in cancer, people who exercise tend to do better. So make that part of your daily management, okay? It's not running a marathon, anything like that. It's just getting out and expanding your lungs and getting your circulation going, so exercise. There's a lot of websites out there, and I know that you're seeing them. I tend to follow, I followed this woman for a while, it's Joan Summer. And I'm probably echoing a little bit of what Yvonne said, but she talks about surviving and living with ovarian cancer is not an arbitrary period like 5 years. It's an everyday thing where you wake up, take a deep breath in spite of your fears and pain, and find a way to take your place in the world. And then she goes on to say that surviving cancer is not a place you strive for in the distance. It's here, and it's now. You're in it. It's up to you to be a part of it and find your own hope. And the last thing she says is hope is falling asleep and expecting to wake up each day in spite of what you might have heard. It's thinking about the possibilities and not the probabilities. It's preparing to die but expecting to live. So I'll leave you with those messages, and I'm very happy to take questions as a question and answer session. Thank you.